So I'll just tell a few cases. And of course, you may be wondering why I have not told the case. But first I thought it is always good to know some physiology, the basic fundamentals of a echo. And what is it, and how can we use it, and where can we use it, and how can we learn in a better way. So a 30-year-old man with a history of deep vein thrombosis and pulmonary embolism came to the hospital with a complaint of left facial numbness for 5 days associated with hearing loss in the left ear and ataxia. The echocardiogram was done and the results are shown in the next slide. Next slide. So there, you see, so you know that this is the left ventricle, right? So there is a thrombus here. So some amount of a little bits of it have gone, and then it has gone up to the brain. So that is why if you do these things, thrombus in the LV. So small pieces sometimes break down. So these are difficult cases, and how you treat and all, you have to read up and do all that. It's not my it is not today's forum to tell you all about it, but I'm just saying that this is the history. He came here, and then when we did the echo, this is what we found. So immediately, whatever has to be done was done in the later thing. But these are very tricky cases. They, even if you do everything, a small bit can go and get dislodged and go and cause more paralysis and more trauma, and I mean more brain injury. Okay, next slide. So next case is a 68-year-old woman with a medical history of hypertension, diabetes mellitus, and obstructive airway disease came to the hospital with the complaints of chest pain. But the ECG did not show any reveal any ischemic changes. So somehow they did, and then troponins were negative. So most of the time when the troponin I also is negative, then we think it is not really myocardial or acute coronary syndrome. It's sort of a ruled out. Then they did an echocardiogram, and the results are shown in the next slide. Next slide, please. Yeah, here. So don't read there. Look at it here. This particular, this is the left ventricle. Okay. And the apex is sort of ballooned out, right? Apex is ballooned like this. And the base is not, okay, it's sort of little irregular. So when there is like this ballooned out, you call it what is called a Takotsubo cardiomyopathy, which comes with a lot of stress. Or sometimes when you give it to some people, you give a lot of dobutamine, you give a lot of dopamine and things like that. The sympathetic stimulation or adrenaline, you constantly keep on giving them, nebulizations, things like that. Sometimes with the stress, they can go what is called this classic Takotsubo, where this balloons out. You remember the octopus? The octopus is like, with all its tentacles coming out, but this one is little balloon like that. So it is compared to an octopus in here. So if you look at that way, then you can think that there must be something. Is there a cardiomyopathy because of the stress, and find out a little more. She is hypertensive, diabetes, and also a lung problem is there. She may be taking a lot of, the inhalations and things like that for a long time without proper realization. Or if they came with some other thing, they've given her other things. Or if there was a bad stress in the family, so anything can be pushing them to that side. So sometimes we see this often in a pregnancy. Okay. So, and we see it in younger women. So you have to be keeping that in mind when suddenly there is nothing in the myocardium. Is there anything ballooning out like that, the apex? Then you have to think about it. Next. Next. Yeah, a 38-year-old man with a end-stage renal disease who is currently on hemodialysis came to the emergency department with complaints of shortness of breath. ECG showed low voltage complexes. Then echocardiogram is done. So in the echo, what we have seen, normally this is the pericardium. See here, the dark one is the fluid. Okay. So this is the fluid. This is the pericardium. You can see this. And this is the fluid. And this is the fluid. So this one, what is happening is the pericardial effusion in this particular patient with the renal disease has become so much, because we see pleural effusions often in patients with renal disease. But there is a lot of pericardial effusion. That's why he came with a shortness of breath and low voltage, complexes. There is no chest pain, only shortness. And so the ECG showed low voltage complexes. He is a renal disease patient on dialysis. Maybe he did not get his dialysis for some time. And also there is always a chance of little infections for these patients. Next slide. So this is another woman, 53-year-old woman, history of hypertension, diabetes, chronic obstructive pulmonary disease, and came to the emergency department with severe shortness of breath for 1 day. ECG did not show any ischemic changes, something like that. So bedside echocardiography was done. Okay. Now you see the right atrium is a little more, right ventricle is bigger, and there is a small, I think that's the embolus, because they put it in this way. I'm not able to tell you, but it was some amount of pulmonary embolus, little blocking there and causing an increase in the PA pressures, and then sort of increasing this, even the right atrium is also, little bit. And here a little bit, after a little while, what happens? This will also will be towards that. So these are some of the things which can be seen, and we can have a problem in the next, because she was having a lot of, breathlessness and all. Next slide. A 47-year-old woman with a medical history of hypertension, non-ischemic cardiomyopathy, and status of post-aortic valve and mitral valve, okay, replacement 5 years ago, came to the hospital with fever and shortness of breath. So now you can guess, this lady has valves replaced and she has been on for 5 years and it's going on. So here you can see these are the things which you have got a little bit of whitish things here like that. So these are towards the, if it is mitral valve, which is supposed to be mitral valve, and these are supposed to be a little vegetations coming into the atrial side. Okay, so those are the vegetations which you can have in the mitral area. Next. So now when we come to the last case, I had one patient who came to us, is a 36-year-old male patient. He was immediately shifted to the ICU with a history of shortness of breath. He slowly had shortness for about 10 days. It gradually increased. Then as soon as he came, he was so short of breath. Then immediately they did an ultrasound of the lung and there were tremendous number of B lines. So there is pulmonary edema. Okay. And the patient was so much breathless. Immediately they found out that he also had a mitral valve placement some 10 years back. Okay, a bileaflet mitral valve. They did not understand all those things. They said he had some mitral valve surgery and immediately they shifted to ICU. So as soon as the patient came, they gave him Lasix. We also gave Lasix and put an NIV so that at least his breathlessness and improves the oxygenation. Then immediately we took a little echo, and as is always put them with a little head up, unless of course the BP is very low. So we have put him like that with 1 or 2 pillows, not really follows position, but just make him comfortable. Because why you should put head up, you should know. Whenever you lie down, the pulmonary blood flow is much more than when you are sitting or standing or even having a little bit head up, about 20, 30 degrees. So that is the reason you will reduce the pulmonary blood flow. But you can also reduce the systemic, the hypotension can come. So you can't do that in a hypotensive patient, but you can still do manage with a pillow or something like that. So he was on a regular follow-up, this man, but he came with this. He was having a little bit of breathlessness, but he was saying anyway, it will be there, something like that. So we applied NIV. Then I myself did a echo on that patient. Then I saw the valve is not moving. I mean, I could not show because the things were not coming nicely in a video. So valve was not moving. I felt the valve was stuck. So immediately I called the cardiologist. I called the surgeon, both of them. And we have taken the opinion because it is so long, 10 years, and it's a bileaflet valve and it is stuck. I don't think a thrombolysis would be very useful. They both decided, and the patient was taken up for surgery and he survived. They replaced a biological valve and he used to come for follow. So we were given, at least my surgeon was very happy that we diagnosed a stuck valve and called him. Okay. So these are, next slide please. So these are some things. So here, see, this is the mitral valve. I just took a picture of that. So it is something normally if you say it will be going up and down like that. Okay. So here it doesn't go, and so it is sort of a flat like that. Next slide. So this also can be to an extent diagnosed. I'm not saying everybody can diagnose. So what do you do when there is a, is it surgical intervention all the time? No. Most of the time it is thrombolysis is useful. Most of the time the cardiologist will do thrombolysis, and number of studies showed quite a good improvement. But there are exceptions to all the general rules. There are always exceptions. Mechanical bileaflet valves for a long time, these are some things which can grow a lot of material fibros around the valve. The adherent thrombus, the thrombus becomes adherent and sort of a panis. It forms like a, it blows out in various ways. And long history of valve replacement. Sometimes, even if you do this, later on you have to do thrombolysis, you have to do the valve replacement. So sometimes they think it is better to go, in a rare instances, better to. Next. So that is what thrombolysis or versus reoperation. No problem. Next slide, please. So today I have tried, I think I have done fairly well in about 50 minutes. What my take home message for each and every youngster or even an older person who has listened, who wants to do echo in the ICU, it's only beginning for you. You have to be looking at the number of normal echoes. When you go to do ultrasound, it has become so common now. When I started that ultrasound in ICU in 2010 or 12, hardly anybody was doing. But we had so many workshops and we did so many things. Now echo has become part of it, and it has become the point of care of ultrasound in the ICU. So you have to do, when you're doing echo, just put the other probe and see how the heart looks. There's nothing wrong. Nobody is going to charge for that, right? Anyway, you are charging for ultrasound. So just see how is the heart working. So you see it in a different views. That is what, as a youngster, you have to do and train yourself. Nobody is going to sit and hold that, echo probe and tell all that. So you can learn that in your spare time. When you do ultrasound, you can just do this. Then sometimes if you are, your cardiologist has come, many times they do come and do an echo. Be with him and ask all the questions which you are having a doubt, and ask him to show you, how do I calculate VTI? How do I calculate this? How do you calculate the, LV ejection fraction? How is it? Is it coming on that? So what else can I learn? Okay. So then you have to have a posting in cardiac anesthesia. If you are an ICU person, I send you at least for a month to cardiac anesthesia and a month to the echo room, so that you will learn from both cardiology and from anesthesia, the monitoring from there and the base from here. So, and attend number of workshop and hands-on training. So this will give you, my message for you is to learn in this way. I mean, I did have some amount of learning. I can't say I learned everything, but at least I have learned, I kept up my learning, so that even at the end, when I'm finishing, I can still talk about echo to all of you. Okay. So next slide. Is there an, so what is this? Can anybody tell me? Can you mute some of them?
Doctor, they can write it on the chat box. I'll be narrating.
Yeah. Ask them to write.
So please write it on the chat box. Please let us know what exactly do you think You
Yeah,
can
yeah,
see it on
yeah.
the screen.
So this is one echo, and this you can write down. You can
Dr.
show them.
Santosh has written pericardial effusion.
Cardio.
Pericardial infusion.
Very good. So he has understood what I have.
Dr. Ashima also has written the same answer.
Ashima will tell. Okay. So this is pericardial effusion.
So,
See the whole thing here. It's all
Daya
surrounding and, you know, compressing the heart. Okay.
Okay, Dr. Daya has written cardiac tamponade.
Yeah. So that is pericardial effusion, you know, crushing the heart. So,
Okay.
so you all understood what I've said. Good.
Dr. Pawan and Dr. Mohan, everybody has written pericardial effusion.
Yeah, those are all Pavan and all are they already do these things. This is basically for the youngsters who are students. Okay, right. All of us are students for life. Next one. So what is this one? You can write down.
Please write it, mitral. Dr. Daya has written.
What is written?
Mitral.
What is this D which I have shown here? I talked about it. What is that D sign? Why is the right ventricle more? It's showing like a D, no?
Okay.
And it is pressing onto that. So it could be
mitral valve, Dr. Umang.
Mitral valve ikkada idi left, idi right.
Dr. Daya has written aortic dissection.
No, that is not aortic dissection. Others, anybody has written?
McConnell, Dr. Ashima.
What is that?
McConnell.
Metform.
1 minute. Hypertrophy. Dr. Daya has written hypertrophy.
No, it's not that. See, it's a little pulmonary embolism. Okay. So that is what I'm saying. It is pushing the septum and the left ventricle is becoming so small. Here you are having a big one like a D. That is what happens in embolism. Okay. Next one. Next. This one. What is this?
RA dilated.
RV Adi. That is not RV. That is not RV or LV. It is aortic dissection. You see the flap? Something like that. So if you are looking at aorta and you see that way, that means it is a dissection. Okay. So these are just a few of them I wanted to show you so that you can always go and look at, you know, patients.